We're live. All right. So we are gonna be doing another live thingaroo here. So I don't think my babies are asleep yet. So if they run out here, we might end up cutting this thing early. So that's just the way it goes. So and I also have like a new little puppy running around. So if you see me running around playing with a puppy, if he comes. If you hear all kinds of craziness going on, that's what's happening. So, week 7, here we are. So this is like halfway through. I'm all done with half of my residency. So I've been on a medical unit now for 6 weeks, and that's now finished. Now I'm going on to my other next 6 weeks, and then that'll be that. I'll be done. And so, in next month, maybe 5 weeks from now, what is it? Look at my calendar. So yeah, so I think, oh gosh, keep looking. Today's the 11th. So 1, 2, 3, like 4 more weeks. So in 4 weeks, I will know where my home position, my home job is. So we'll see where I land. I'm kind of on this ICU kick, and I'm kind of on this like CRNA kick, and I think, I don't know, I don't want to jinx myself, so I'm not saying I'm going to be a CRNA. I'm definitely not saying that, but I'm going to at least give it a go and see how it goes, because if I can get a couple years, 2 or 3 years of ICU experience, get my BSN, keep a really high grade point average. Looks like they take people. It's not like they don't take anyone. So, like, there's a lot of programs. And it's like 3.5 years of, like, nursing school on steroids. And I'm kind of up for it. I'm like, shoot, man, why not? Why not? So, I've been studying just been dabbling, just dipping my toes in the water of, like, some anesthesia pharmacology. And one thing that really hit me that I thought was so, I don't know, just tripped me out because I never thought of this, and I don't know why I had never thought of this. It makes a lot of sense. But the lungs get 100% of cardiac output. And it's like, duh, of course they do. But that's helpful when you're giving medications, anesthetics, into the lungs, because it really gets stuff going fast. Considering like this arm, like my arm getting some venous return, how much of my cardiac output goes to like one AC, one cephalic anacubital vein. Not nearly as much as the entire surface and parenchymal surface of your lungs. So when you put that mask on of like, I guess, so we have like, I guess SIVO, or something called SIVO. What is it? It's late. It doesn't matter. So anyways, these medications, you put them on, and they start breathing, and it's like just boom, hits them really fast. I just think that's pretty trippy. I just love that was like one of the first things they said in that little lecture. I'm like, wow, man, that's intense. That is pretty crazy. So, and I mean, that's just one little tiny thing. What do I know? I'm just a brand new little newbie nurse, so I know just a little bit. I don't know a whole lot. But I just, that's a little tidbit that I thought was interesting. And I really think I would like that job. I think I would. And I think I would like ICU. I like ICU stuff, and I love the medications. And I love taking care of people, and we'll see. Maybe it won't fit me because I like chatting too. I like talking to patients. All right, I don't know if this is going to change my camera. It's going to mess my camera up the way I just moved, but whatever. So, yeah, I like talking to people. I love chatting up with my patients. So, I don't know. We'll see. See if I get tired of chatting it up with patients. I just want to put them to sleep. I don't know. I might be good. I think it might be a good. Position. Like say 5 years down the line. So like I'm thinking that way. I'm like, okay, 5 years from now, my oldest daughter will be 8 or 9 almost, and my youngest daughter will be 7, and maybe we'll have another baby. Like let's say I have a baby at like the 2 year mark or 2.5 year mark of my residency or my CRNA program. So like 5 years from now, we could be done with CRNA school, and I could have a 9-year-old and a 7-year-old, 5-year-old, 9-year-old and a 5-year-old, or 5 or 6-year-old, and like a 2-year-old. So I could have like 3 kids, be taking my boards, and I guess I see myself there. So that's why I guess I'm like, shoot, man, I kind of see myself there. So we'll see. We will see. I've seen lots of people going into the CRNA school. I'm like, dude, I'd be willing to give a crack at it. I love all that stuff. I love all the science. And I got to start at ground zero. So like I'm starting for my BSN. So I got to get that BSN first. And I only have one writing class. I'm only taking one writing class. So I got to take writing 2. So I got to take writing 2. I think I might have to take a chemistry class or microbiology or a biochem. So I got to take writing 2, a biochem, and a statistics class. I think I got to take all 3 of those before I can even apply to BSN program. I think. I don't know. I'm looking into it. I'm trying to look into it right now. I'm seeing if I can bang those 3 classes out at my local community college. Just bang them out and then apply and start in spring of next year. And and I'm probably not going to go full-time. I'm probably going to have to go part-time, just like I've gone part-time through everything else in my life, because I want to get straight A's. Got to have straight A's to go to CRNA school, right? Or like it's ideal, like it makes it easier to apply. If you have, and I interview well, I think I interview pretty well. So if I can have good grades, good experience, good interview, might make sense. And I don't really want to take the GRE, so I'm going to try and skip around that if I do. See, I've been like thinking about this. I'm like actually putting all the pieces together, and I see a plan. I'm like, I see all the steps in place, and I see a plan. It's like, we're just getting older anyways, why not do it? Like, I'm just getting older. And not that I don't want to work at the bedside. I love working with patients. I love working at the hospital. It's a blast. I think it's super fun. But I'd love to, work towards becoming an airway expert. I think that'd be amazing. Anesthesiologists and CRNAs are airway experts. They're amazing at what they do. And I just would love to have that, technical training. I think that'd be really, really fun. And I love responding to code blues. Code blues. I not only get to respond to code blue, I get to, do the airway for the code blue. That's fun. I'm super down for that. That's a blast. So, I'm learning to trach, like learning to put in a trach, or like cricothyrotomy, putting in art lines, putting in central lines, using ultrasound guided, cannulation. Like I'm all for that. Like I love all those skills. I'd love to be able to do all that stuff. So like why not, man? Why not do that? Why not? Especially if it's not going to be impossible. I mean, it's totally possible, I think. So I don't know. I think it'd be cool. That's kind of where I'm at. And I mean, I'm looking at my little screen. I'm like 7 weeks into my new grad residency. I'm talking about CRNA school. So that can be a bad look too. That's stupid. So this is 5 years. I'm at least 5. I think at least 5 years down the line. But it starts today. And it starts with intention. I think it starts with my intention, meaning don't get complacent. Don't go sit on a medical floor and say, oh, it's easy. I can sit on a medical floor. Like I kind of got 6 patients down, like no problem on a medical floor. Like that's not. It doesn't I don't think it really ever stressed me out after week 2. Like week 2 was a little stressful, Like, the first 2 weeks were stressful, and then once I got the system down, I'm like, dude, let's take 6. So, like 6 patients is manageable for me on a medical floor. I'm like, I don't want to just do that. That's not what I'm interested in doing, is just collecting a paycheck and just being a floor nurse. Like, that's fine. I'm okay with being a floor nurse. Like, I don't mind floating to medical. Like, I'm cool with it. I love it. I love the unit. Like, that's the problem. Is like this unit I'm on right now. I love the unit, but it's not gonna push me, like cerebrally. It's not gonna push my critical thinking skills to the level that I'm looking at. So, and I think I've talked about this pretty much every week, about my, wanting to have patients who are a little bit on the sick side. Like, I don't want my patients getting sick and then I send them away. I want to manage them, call the doc, get the doc to the bedside, get the interventions done, and then manage them. You know what I mean? So, I don't want to get complacent. It starts today. I need to get focus on educating myself for critical care, educating myself, and like our ICU uses Impellas. I love Impellas. Always wanted to touch Impellas. I read the policy on the Impellas, and it's a little daunting. And I definitely would love to be a part of some education on how to run the Impellas. For anyone who doesn't know what an Impella is, my nose is itchy. I don't know why my nose is itchy, but I keep itching it. So, an Impella is like a big McFlurry straw with a little like vortex spinner at the end of it, and they cannulate it up through the artery, and they sit it through the aortic valve. They go through the mitral valve, and then half of it sits and in the ventricle, and then another half of it sits outside of the aorta, right? The semilunars. And so it'll spin like 2.5 liters of cardiac output per minute as a like LVAD, like a ventricular assistive device, spinning, boom, shooting blood up out of the aorta systemically. It basically takes 2.5 liters of cardiac output off of the left ventricle, allows it to operate at with less effort, and it's for someone who may have crumped in the cath lab, who needs some ventricular support because they are, their heart's pretty stunned and it's not doing what it needs to do, and you can't just run freaking pressors on somebody and make the heart work. Like, you can't make the heart work harder. That's the problem. Like, okay, so this is my thoughts, and this is kind of, I think, one of the things about critical care medicine when you're dealing with cardiac output and heart dysfunction. So you have the heart's not pumping, right? So it's working hard to pump, so you're losing a blood pressure because the heart's not pumping, ejecting enough fluid, right? But so the blood pressure's dropping. Well, if you give a vasopressor, right, and we clamp down everything, systemic vascular resistance increases, and it makes it even harder for the heart to pump against that, right? So thinking, oh, they're in cardiogenic shock, let's put some vasopressors on them. Well, that's going to cause more problems sometimes. There's just, there's a lot to it. And so I think that's one of the reasons they like to use these assisted devices, or like intra-aortic balloon pump, or an Impella device, or a left ventricular assisted device. Hold on a sec. So we use these things that help mechanically alter or lessen the load, O2 demand on the heart. And like ECMO is like ideal, right? Throw them on ECMO, let the heart rest completely. So that's why ECMO is so revolutionary, and that's something that I'm really interested in doing. And if that means I have to, I'm all for ECMO. I think it's incredible. So I feel like that's the next step in advanced cardiac life support is ECMO, because you get to let that heart completely rest. You can feed it oxygen and let it rest and let it recover without actually even having to beat. So it's called, I think, VA ECMO, veno-atrial ECMO. And I think one goes in the femoral artery, and then one goes in like the internal jugular. So you have one go in the artery, one go in the vein, and it bypasses the lungs and the heart, kind of shuts everything off, and you're oxygenating extracorporeally to kind of give that cardiac the cardiac stunning that happens with cardiac arrest. So when the heart, so what they're finding too, there's another thing, is when your heart stops beating, right, when it's ischemic and you're trying to reperfuse it, you can have what are called reperfusion injuries. So like you have all this tissue that's been out of oxygen for a long time, and it's just sitting there, and it's becoming acidotic, and it's becoming it's gone through the glycolytic pathway of lactic acidosis building up, and then no blood flow, right? And all the cells are starting to kind of disintegrate and break apart. And then all of a sudden, you pop the spigot, right? You reperfuse it, flood it with blood, and then it actually causes damage to the tissue. Like it just, it smashes all the tissue that was all broken up, right? So you can have these reperfusion injuries post cardiac arrest. So even if you get them back, their heart's still all messed up. So what is happening is like there will be like days of post cardiac arrest where their heart is like stunned and not able to pump effectively, but the brain still needs oxygen. The body still needs oxygen. You still need to have your kidneys perfused. You still that heart still needs to be pumping, even though it can't. And so by putting them on ECMO, the heart doesn't have to pump anymore. It gets to rest. And just from the little bit of research I've done, seems to really, really help. Seems to help outcomes with that. So I guess that's a random rant about VA ECMO that I know very little about. I mean, I know just a little bit about, I know a little bit about some stuff. I don't know a lot about anything, really. I really don't know a lot about anything. I know a little bit about a lot of stuff. And so I'd like to start, narrowing down my, field of study so that I become more specialized in one specific thing. And if that means going ICU, and then cardiac ICU where we're working with Impella devices and intravenous pumps, and then even more specialized, to like ECMO, VA ECMO, or VV ECMO. That would be freaking sweet. And like CRRT, like being able to manage CRT, I think I love to be able to figure that one out. And just all the stuff that comes with ICU. I think I love that stuff. So that is I think the goal, right? So if I want to be a CRNA, that's 5 or 6 years down the line. What I need to focus on right now is become the best ICU nurse I can, preparing myself in a way that allows me to test my knowledge of pathophysiology and pharmacology and medical intervention associated with their diagnosis, and improve my communication skills and improve my assessment skills, and just all around start building these skills. That's the goal for the next 2 or 3 years, I think. And if while I'm doing that, if I can get a BSN, keep my A's, get a CCRN, I think that would be, and then make some money, and that's the thing is for me, money comes second, it's money or third or fourth or fifth. I don't really care about the money. As long as it's paying for my family, as long as we got food on the table, as long as my house, my mortgage is paid, I'm happy. I'm not worried about, I'm not really too worried about how much I'm getting paid right now. I'm not doing it for the money. I'm doing it for the expertise and the experience and the fact that I get all giddy and excited about these things. I just need to follow my dreams and follow my passions, I think. And that's kind of where I'm at right now. So, and it's only 7:30, and I feel tired. I feel so tired. So, which is okay. Oh, so I'll talk about some more random crap. So I'm going to be switching to night shifts coming next week. My first shift is going to be on Tuesday. So switching night shifts, and I'm switching from a medical floor to a surgical floor. So surgical, I think I talked about this last week again, but heck, we'll just keep talking about it because it's happening now. So with surgical, We have really, really, really great orthopedic surgeons, great orthopedic program here at the hospital I'm at. So they really do a lot of, I think, total hip, total knees, um, like foot and ankle stuff. I don't know if they do spine stuff as much. I don't think they do spine stuff, but foot and ankle, knee, total knees, and total hips, like they do those like crazy. So we're going to be taking a lot of those patients um, and recovering them, and then discharging them because they discharge late. Apparently, we start around 5:45, and we'll get like post-ops coming in at like 6, 7 o'clock, 8 o'clock, and we got to recover them and discharge them that night. So that's like a thing. I guess it gets kind of crazy at night. That sounds kind of exciting. Sounds like up my alley. I love being busy. I love being busy. I did not like just sitting around. So if I can stay busy, I'm happy. I like doing stuff. Maybe I won't do well as CRNA then too, because like once you get the patient's airway managed, they're under the operations going. There's like a lot of blast and cruise stuff where it's like you get them. There's a lot of work in the front end, and then it's really quiet, kind of waiting for them to, managing their vitals. And what the heck do I know? I've been in the OR a handful of times, talked with an anesthesiologist maybe 3 times. So what do I know? But from what I hear, it might be a little less busy. I could be wrong though, and I know in residency it's definitely not. I've watched all these like vlogs, of people who are doing like student CRNA rotations, and they are like running and gunning, man. It's like one code blue after the next, like a high risk OB that you spinal block and then end up tubing, or like all kinds of craziness, and I love that stuff. That's fun. So like maybe being, and I love rural medicine, so I don't know if like once I'd finish, like being an on-call anesthesiologist might be kind of fun, especially if it's paying you well. Like that'd be kind of sweet. So I guess those are my thoughts for the day. I don't know. I love this little puppy. I got a little mastiff here, and he's sleeping at my feet right now. A little 7-week-old English Mastiff, and he's like the sweetest little dog. So I'm enjoying that while I'm not, and my babies while I'm not working. But I'm just gonna keep making this, I guess, about work, and we'll just see what happens. I don't know. I don't know. I guess that's all I got. Is there anything else? I don't know. Maybe I'll just think for a minute. This is what happens. I do a live video. I'm like, I'll just go live, just chat it up about, do a little brain dump, stream of consciousness brain dump, and see how it goes. I don't know if it's any good, but this is what I'm going through right now as a new grad. I was told kind of that I was supposed to hit a wall of like, 3 or 4 patients, and then you can't really do it anymore. It gets hard or something. And I got up to 6, and I never really hit a wall. So that tells me that I need to keep advancing and keep pushing myself, because I don't know. It wasn't. I don't know. I don't know what it is, but I want to keep pushing myself. It tells me that I should keep going, I think, and not just settle. Like, oh, okay, maybe I'll stay on medical here and learn stuff. It's like I got time management down. I got 6 patients down. I got time management down too well, because I can pass my meds and do my assessments and basically go get some breakfast and call it a good and be done with my morning meds like before MedPass is supposed to be done. Like before 9 o'clock, I can get all that stuff done. And like I've got my morning down, and I've got like my time management is not a problem. Communicating with family is not a problem. Like I'm able to keep myself going. I'm able to anticipate what's going to have to happen like an hour or 2 before it happens. I'm able to so I'm like, this is not. And it's not anything. I mean, it's like whatever. I don't know. And I've been on the floor a lot, and I've worked with a lot more patients. So, I think that prepared me really well for this. So I'm like, well, I don't want to just keep doing the same thing over and over. Like, I want different patients and different things, and I want the sick patients. I really want the sick patients. So that's kind of where I'm at. I really want the sick patients. I want to get used to all the critical drugs and all the critical care stuff. So eventually, I'm gonna get there. I'm just gonna keep on studying, keep on plugging away, because I'm still studying like stuff. Like, I still listen to lectures. Like, school never ended for me, really. Like, I took a break, but you know, I love studying. I just can't. I don't want to stop studying. And if that's the case, I might as well keep advancing my career. You know what I mean? It's like, don't just study for study's sake. Study and then apply it for something. You know what I mean? So, um, I guess that's what I'm gonna do. I'm just gonna try and do that. So that's 26 minutes. Boom. I'm gonna call it. That's it. So I'll be back next week, and we'll see how the night shifts go. See if I can keep myself alive in the night shifts. So there we go.